you. So if you want this, first of all, I want to say what a fantastic work you guys are doing here in Michigan. I'm really impressed. This is, as you know, infrastructure building, and that's a hard thing to sell to people, but you have to build the infrastructure while you use it, because if you build infrastructure that you're not using while you're building it, you're not going to get what you need or want. So there's this hard pathway of building the road or building the railroad tracks while you're running down with a train. And but that's when you know you're getting it to the right place and it's going to be tested and work. And so thank you. Also, some of the things that you're building, you're the only ones. The work here of this synthetic patience that you heard, I know it sounds a little bit kind of dry and technical. It's incredibly powerful and important, because the only way we're going to all be able to know that our systems are calculating things the same way is if we actually can share data back and forth and say, are you getting the same result that I am? And that means somebody has to invest in creating a bunch of information, synthetic patients, that we can move back and forth and say, yes, health plan A gets the same results as health plan B with the exact same set of inputs. So you guys are investing in that, you guys are doing that, NCQA is doing a bunch of work in that same place, but there aren't very many people that are doing it. And so thank you to you. One caveat and highlight that you might be interested in, a lot of places I think aren't ready for this yet, but you guys might be. We haven't talked too much about the government-funded open source technical tools that support this work. But if you're interested in those, there's a website called the ECQI Resource Center, and you can just Google it, ECQI Resource Center. And we have tried to put in one place the set of government-funded tools and programs and applications, tests, et cetera, government announcements around these standards you've been hearing about, the QRDA standard, but there's actually a number of tools there as well. One tool that a lot of people use, I know MiHIN has been very involved in, is the Cypress tool, which is the tool we use to test and certify electronic health records, ability to do this quality measurement, their ability to do QRDAs, for example. We've been building, and this is the thing I think that might be news to some of you, we've been building a new tool, and it's in its testing phase, called CEDAR. And if you think about Cypress as a tool to test that EHRs can actually send out the right kind of data, CEDAR's designed to test things like health plans and Medicaid programs that they can consistently take in the right kind of data. So they're kind of sister tools, sister test harnesses. And the idea would be you could say, we've got 12 health plans in the state. We want to make sure that when they take data in, they've all done it exactly the same way. And CEDAR is the tool to do that testing to make sure that they're all doing it the same way based on the standard that we've agreed on. That tool is fairly new, and it's in its kind of early alpha beta testing mode. But we think that it has a lot of potential. The reason we're investing in it as the government is to try to be sure that we don't have 50 different Medicaid ECQM systems, but instead have a way to say there's a consistent standard that state Medicaid ECQM systems are using, lined up to the system, the ways that data is coming out of EHRs, practices, and other places. But again, thank you very much. So I have a few slides here for about the MACRA and MIPS program. These come from a much larger slide set. This was 94 slides altogether that I cut down to a tiny little bit. So if you're interested in those, if you go to the Health IT Policy Committee website, and just Google Health IT Policy Committee, there's a section in there that talks about a joint committee that deliberated on the MACRA policy, and that's where the slide set comes from. It's open and public. Disclaimer, I won't necessarily get into all these key topics, but this is some of the basic information that I'll cover. The healthcare quality payment system and the Secretary's goals. What is it? How will you submit comments to the proposed rule? Some details on the merit-based incentive payment system. And then a little bit on the alternative payment models. So we've mentioned this a number of times. I won't go into it too much here, but just to say we are committed as the federal government to value-based payment. We are committed to advanced payment models. We are working very hard and very aggressively to move from fee-for-service to value-based payment. In much as we can, help and support not just that through federal payment, but through Medicaid, and how do we help and support the private sector insurance companies to move in the same way many of them want to. So we've established things like collaboratives of insurance companies to get together to think about how they can move to value-based payment together. So we are committed. So the Quality Payment Program, which is what's coming out under MACRA, so Congress wrote the MACRA legislation, the Medicare Authorization and CHIP Reauthorization Act. So many of these things are not things we can change as federal regulators. The way I kind of explain to my mother what I do is Congress gives me a coloring book where all the lines are, and my job as a federal employee is to color in the lines that Congress gave me. And so there are some things I can actually change inside there with the colors, but I can't change the lines around which the programs work. So Congress gave us that structure for what MACRA is, and then our job with these proposed rules is to color in the lines and then say, hey, did we get this right? Give us some feedback about what those were. An example of that is in meaningful use, Congress is who decided who was eligible and who wasn't. So as much as I might have personally liked to say, hey, behavioral health providers, here's meaningful use incentive money, that was not within our power as a regulator. That was fully decided by Congress. So there are many parts of this that Congress gave us the direction for. But the basic things it does, it repeals the sustainable growth rate formula. It's designed to streamline quality reporting and align it into single programs, a more of a report once model to the federal government. And then it does these new incentive payments for participation in advanced payment models. And it attempts to say, if you're in an advanced payment model, you won't have less requirements for lots of other kinds of reporting and activity, because our goal is to get you into these advanced payment models, and we believe that those advanced payment models in and of themselves will be the biggest drivers of quality. And the goal here was that we got very clear direction from on high. Don't just do what we've always done with meaningful use and PQRS. Think of this as a new program. Use this as a fresh start. And we're really trying to be very attentive and listening to you and your input and feedback all the way through the process. I'll talk a little bit more about that later as it comes to quality reporting. This rule is out as a proposed rule right now. That's the government process that I think many of you are familiar with, where we write a proposed rule, and part of my constraints are that I can't clarify things with any of my own commentary above and beyond what's actually in the proposed rule. While we're in a proposed rulemaking period, I can only say what's in the rule, and if it's not clear, plead with you, please send that in to us, because we want everybody to have clarity. So if we don't have clarity in the proposed rule, this is your chance to tell us it's not clear so we can get it clear by the time the final rule comes out. Another part of the reason I can't add any clarification is that we can't give anybody inside knowledge in what may or may not be coming in the final rule, because then it gives somebody potentially a commercial advantage. So here's where to do it. The comment period closes on June 27th, so you still have a few weeks. I know it's long, and I know it's hard to get through, but it's a big deal. So MIPS, the Measurement Incentive Payment System, is the first step to this fresh start. It's combining three current programs: the quality program, which is PQRS, the resource program, which is the physician value modifier program, which I think it's actually been around a while, but a lot of people haven't been paying that much attention to it. But it gets combined into this new program. The Meaningful Use Program, which because we're really trying to reframe it in a much more flexible, open, non-threshold based way, has been renamed the Advancing Care Information component, and then an additional component on clinical practice improvement activities. So the idea here was to provide simplicity and flexibility, and I'll tell you, it's not easy to do both of those things. It's easy to be simple and rigid, and it's easy to be flexible and complex, but to be flexible and simple is not straightforward. So if we didn't get it right, please give us input. So one of the first things to understand is who will participate. And so these are MIPS eligible clinicians. I think the easiest mind map for me is it's pretty much equivalent to PQRS eligible providers. And so these are intentionally named clinicians, not just physicians, because we've got PAs and Ps, clinical nurse specialists, and later on, audiologists, nurse midwives, psychologists, dietitians, nutritional professionals. So there are a number of provider types that if you're used to the Meaningful Use Program, are newly eligible or newly required to be reporting into the merit-based incentive payment system. Who won't participate in the merit-based incentive payment system? If you're in your first year of Medicare Part B participation, so think of that will probably be mostly new graduates into the workforce. In part, that's because you have to have a history, you have to have a period of prior performance for us to actually be measuring against. If you are below a certain patient volume threshold, this is again similar to how Meaningful Use has worked. And if you're part of certain advanced payment models, then you don't need to participate in this system. You've seen kind of versions of this slide. How much will the payment adjustments be? Again, this was set by Congress, so this is the kind of thing we don't have flexibility in changing. Congress told us what the adjustments will look like. We get to pick the methodology and the approach and the weighting within these overall adjustments. So you can see here what they look like, and these are maximums and minimums. A number of people will probably be neutral, and a number of people will get less than the maximum, or either positive adjustment or negative adjustment. And then we will be increasing these adjustments year over year. So a little bit more into the proposed scoring, and again, I'm doing just the kind of high-level highlights. If you want more details, that as I said, this slide set is quite detailed, and again, direct you to the rule. So this was largely set up by Congress, what these weights would be for the first year. We have the Secretary's flexibility in out years to change these weights. And actually, Congress has asked us to change the weight and especially increase the cost weight over time. So it's 50% of the weight is on quality, 25% is this advancing care information, and again, that is the former Meaningful Use category. 15% is clinical practice improvement activities, and 10% is cost. So here is what the advancing care information performance category looks like. What we heard is that people wanted not all or nothing scores. People wanted partial credit for partial performance. And we heard that people wanted more flexibility in the kinds of things they chose and the kinds of things they measured, and they wanted less reporting burden. So these are the components of the advancing care information performance category: protecting patient health information, electronic prescribing, but a decreased requirements for less data to be submitted, The same with patient electronic access. Care coordination through patient engagement, health information exchange, and public health and clinical data registry reporting. So these are really pointing back to the meaningful use stage 3 rule for the details of how they work. But not all of the things in the meaningful use stage 3 rule are shown here as components of the advancing care information performance category. So again, the policy goal here, the policy principle was to stay as consistent to what's been built and what you're building and have been planning for, but to try to be more flexible about how you can achieve partial credit and partial score, and to lower the burden of the number of things to report. If you have a different alternative for this, please comment, send it in, let us know what your additional alternative is. I will also add here for those of you a little bit more about the relationship to the meaningful use stage 3. So as you may or may not know, there are 2 rules for meaningful use. There's a rule that is the CMS rule for the providers, and then there's a rule that ONC puts out called the certification program rule that is the testing and certification rule for EHR vendors. And so when we did the certification rule for meaningful use stage 3, it's called the 2015 certification rule. This MIPS program in no way changes our certification rule. Our certification rule stays as it is. We're still certifying technology to the same standards, to the same things we've outlined. We know the vendors have already been building those. Our certification program is already live. So the certification and the technology and the standards are the same as they have been. What's changing are the requirements on providers with more flexibility and lower burden, and this idea that you'll have a partial credit for partial achievement, whereas before it was all or nothing. Your performance score within the advancing care information, there's a whole kind of point and weighting approach that's here, but your performance category will physicians will pick measures from within these categories that best meet your individual practice. So that it's again designed to be more flexible and more optional, and you pick from within things that were basically already defined in the meaningful use stage 3 rule. So I guess I've kind of described this. The scoring is based on key measures of health interoperability and information exchange. That's what we prioritized. There's flexible scoring for all the measures to promote care coordination and better outcomes. The key changes from the HR incentive program, the meaningful use stage 3 program, we dropped all or nothing. We removed redundant measures that where we hope to alleviate reporting burden, things where people were reporting, everybody was compliant with that, we were getting 100% scores, or where it felt like we were counting the same thing twice. We eliminated the objectives of provider order entry and clinical decision support from the proposed rule, and we reduced the number of required public health registries that clinicians must report. So you saw on this previous slide, there's a total of 80 possible points, and within this there's this point system, and if you would get all 80 points, you'd get all 25% of this. If you get some portion of the 80 points, if you get 40 points, you get 12.5% of this, of the total score would then have been your performance on the advancing care information. So I didn't go too much into detail about the quality measure and quality measure reporting component, but there are a lot of slides there. I'm happy to take some questions about it. It is what you'd expect. It's the quality measures that have been part of the meaningful use and PQRS programs, part of the qualified clinical data registry programs, which are again part of the PQRS program. I'm happy to take questions about that and its current policy and the current way that it works. But those are, those programs and those measures are there with a certain number of measures to choose, and 50% of your score will be based on your measure performance. Congress also directed us to have incentives for advanced payment model participation, APMs. So these are ACOs, but they are not just ACOs. They could be other kinds of advanced payment models like the CPC Plus model that you heard mentioned. So not advanced, alternative payment model. So these are new approaches to paying for medical care that Medicare will incentivize quality and value. They're defined by MACRA, so they're defined in legislation. If you don't like the legislation, blame Congress and ask them to change it. The definition asks basically to have some amount of both upside and downside risk in your contract. But it doesn't have to be a government advanced payment model. That's one of the really interesting and unique parts about the legislation. If you participate in a private plan's advanced payment model, so if you're part of a Blue Cross Blue Shield ACO and have enough downside risk and enough value-based performance targets there, you will potentially be able to be part of an advanced payment model and not be responsible for reporting into the MIPS program to CMS, even though you're not in a CMS advanced payment model. So these can be a CMS Innovation Award model. They can include the Medicare Shared Savings Program. They can include a demonstration under the Healthcare Home Demonstration Model. That's a Medicaid program, or a demonstration required by federal law. They must meet these certain criteria. So the participants have to use certified electronic health record technology. That was actually, again, called out by Congress. That was not one of the things that we had flexibility to require or not require. The advanced payment model bases payment on quality measures comparable to those in the MIPS quality performance category. So you don't have to be the same ones, but you have to have quality reporting as part of your requirement to be in this advanced payment model. And the advanced payment model requires that the APMs bear more than nominal financial risk. That's what I was just describing. You have to have some downside risk in this program. Or is under a medical home model expanded under the CMMI authority, and so that's where things like the CPC Plus model will come in. So MACRA does not change how any particular advanced payment model functions or awards value. So it doesn't change Medicare Shared Savings, it doesn't change Pioneer, it doesn't change any of those programs. It just gives you opportunities to not have to participate in the merit-based incentive payment system and only focus your quality improvement and focus your reporting energy into your advanced payment model instead of also focusing it in the Medicare system under MIPS. Excuse me. So here are the kind of ways that these adjustments will go. And so you won't get MIPS payment bonuses if you're in the advanced payment model, but you can get this additional 5% bonus on top of whatever you're getting for your advanced payment model. You can get an additional 5% because you're in an advanced payment model. So the incentive here is that, do what you're going to do with Medicare Shared Savings, and oh, by the way, if it's working, you get this additional money for participating in an advanced payment model to try to incentivize people signing up for these medical home models, signing up for APMs, signing up for shared savings. People look like they're squinting their eyes, like they're confused by this slide. So takeaway points. The quality payment program changes the way Medicare pays clinicians and offers financial incentives for providing high-value care. Medicare Part B clinicians, so not just physicians, but clinicians more broadly. So as you think about your programs and your outreach and your engagement, and think about who's billing Medicare and fee-for-service, and those are the people that will be part of this program. Unless they are in their first year of Part B participation, they become qualified providers through participation in advanced payment models, or if they have a low volume of patients. And the payment adjustments and bonuses will begin in 2019, but as you heard Bo mention, or maybe it was Jason or someone else, don't forget that although the payment changes happen in 2019, they're being measured on your performance of 2017. So it's starting in January of 2017 will be, let's say you pick hypertension, it's your hypertension results of the patients you see from January of 2017 through December 31st of 2017. That score is what will indicate whether or not you get a payment, a positive payment or a negative payment in 2019. Because it takes a year for you to collect the data. It gets sent in at the end of the year. It takes CMS a few months to process that and figure out what your payment adjustment is, and then that payment adjustment is applied to your claims for the subsequent year. So because of this annualized reporting process, we're always a couple years behind in the baseline data used to inform the scores. Another takeaway point for people used to the Meaningful Use program, this in no way changes the Medicaid EHR incentive program. So this applies, and it doesn't change the hospital EHR incentive program. So this applies, the only part of Meaningful Use that changes is Meaningful Use for Medicare eligible providers. Hospital Meaningful Use program still exists. The Medicaid Meaningful Use program for hospitals and providers still exists. They will play themselves out through time. The Medicaid program goes through 2021, is when it was kind of statutorily defined. The Medicaid program never had any penalties. It was only an incentive program, so unlike what you're used to thinking about the Meaningful Use program for providers where you could eventually lose money because you didn't adopt, that never happens under the Medicaid program. So for providers, there's no longer once this kicks in, there's no longer opportunity for losing money in the Meaningful Use program like there used to be. I think that's my last slide. So again, I'm happy to take questions. I can't speculate on what will be in the final rule, and I can't do too much clarifying other than what is sort of laid out in the policy, but happy to not have you be responsible for that, but have me responsible for that. So ask away and I'll tell you if it's something I can or can't say. Question in the back. Oh, just one more minute. I would promise I was going to mention something about the IT systems. So something that isn't in these slides, but we are really committed to a very fresh start with this program. And so one of the things that CMS has done is the system where we're going to take data in for all of MIPS, so it's quality reporting and the other components, is the very first system that CMS is building with Agile from the ground floor. And we've actually been spending the last year doing an extensive user testing with providers about what that system should look like before we write any code. So we've had a number of large design sessions and a lot of feedback sessions with wireframes and models and input ideas so that we build really robust user stories about what it is you are wanting and expecting from your engagement with CMS, about how you understand the program, how you put data in, how we help and support you. And we are building this in an agile test as we go process. So we'll be using standards, but we're also using a fundamentally different way of building our system. So
I had a few different questions.
Yeah.
The first is that I saw that CDS and CPOE were removed under the new regulation. What was some of the thought behind that? Was it that the measures were topped out, or that there was another reason, or?
So the couple reasons. The decision support was always kind of an attestation measure, and so we had a lot of input and feedback that things that you just had to check a box and say, I did this, didn't feel like they were adding a lot of value. I think many of us personally, I personally feel that decision support is one of the most important things you can get out of health IT. It's hard for me to imagine you end up with a robust health IT system and you don't actually have some decision support. So I think it was more about the nature of the current measure as it exists and whether or not checking that box was adding value to the program. CPOE, a couple of reasons there as well. One was that, yes, it was topped out. People had put CPOE in, at least for the areas we had defined for CPOE, computerized provider order entry. There's also a question and concern about, as this advancing information becomes a sort of ongoing part of the program, there may be a number of providers that enter into this for whom CPOE is not appropriate. So if I'm a nutritionist or if I'm a psychologist or someone else, there may actually be, I may not have state licensing to do orders. And what does it mean to have a CPOE requirement with no ability for me as a provider to be doing order entry? And again, there was a question about whether or not it was when we focused the priority on patients and interoperability, the priorities that rose to the top are the ones I highlighted, and those were not the highest priority in patient and interoperability.
Thank you. And I was also wondering about FQHCs. So if an FQHC saw a significant amount of Medicare patients, how would they fit into the MIPS program, or would they not fit into the MIPS program? I'm not as clear about that. So,
if they bill Medicare, they fit into the MIPS program, unless they qualify with an APM. And their additional payments through HRSA have no downside risk. They're only additional payments, so they would have to be in some program that potentially gives them some more than nominal downside risk, which might be with a private payer. It might be part of a CPC Plus program or something like that. But if you bill Medicare, you're in.
Thank you. And last question, I promise. With Medicaid going down the stage or the meaningful use path with stage 3, and then Medicare going down the MIPS advanced payment model path, in terms of quality measures, are there any challenges with alignment that you see, or how does that fit together? I know that's a broad question, but I just
there are always challenges with alignment, right? It's this same kind of flexibility, simplicity question that it's easy to build a really simple program that you make everybody do 3 measures and everybody has to measure A1C, mammogram, and hypertension, and we're done. Chop, chop, chop. The trouble is it's not very flexible, and it doesn't apply to a lot of people. And so what we've done is we have a single measure information system. That's our goal at Medicare, and a single set of measurement policies that come out annually as part of the physician fee schedule. So rather than sprinkling our measures in various programs and therefore sprinkling the different versions and different requirements in various policies and programs, we've tried to align on, I used to talk about this a lot, we try to align on the policy, we try to align on the measure specs, and we try to align on the reporting periods with the information systems all being the same. So that from Medicare, the goal is report once into Medicare, and that will work for your measures across all the programs you participate in. And that's been a big infrastructure and policy change for us, but I think we're nearly to that place now, so that you can submit ECQMs for meaningful use. They count for PQRS, they count for the CPC program, they count for the the Medicare Shared Savings Program. And it's a one submission, but you have a few options for how you submit. You can do those using a QRDA1, you can do them using a QRDA3, you can do them using the GPRO web interface, or lots of different methodologies, but any one path doorway in, you can then apply it across various CMS programs. Yeah.
What certified EHR system do I have to have?
So the certified EHR system is any system that you can certify, and it's a modular EHR certification program, which is designed, again, this is this flexibility versus simplicity approach. Our rule defines what certification is, and you can clarify that by going on what's called the CHAPL, the Certified Health IT Product List, CHPL. and see if your vendor product is certified.
My vendor is certified for 2014. So are you going to have so is it going to be a
2015 certified product. I mean,
Okay.
there's a lot of transition time in this, so I didn't get into all the details of the transition time. If you don't like the details of the transition time, again, give us input, but the goal was to give you plenty of time on the 2014 product, but eventually move everybody to 2015 certification, and then eventually requiring the 2015 certification. I can't remember offhand what year we finally landed on, but there's a sort of year into the future. Yeah, it's 2017 or 2018. I can't remember offhand, but it's a year or two into the future. I think it's, if I remember right, don't quote me on this, 2017 it's optional, and 2018 it's required as part of the rule that you're on 2015 certified technology.
And then just briefly, how do you report your quality measures?
So you report for the merit-based incentive payment system, you report it into the new merit-based incentive payment system module. It'll be a new IT system stood up by CMS to report for this program. Until that time, you report them how you're reporting now. You report them into PQRS, you report them into MU, you report them to the gPro web interface. There are all those different options still exist. As I said, we're building the new system to take all this data in at one time. That will be the data for all of the Medicare programs.
So I will now be able to get incentives through Medicaid and Medicare, because we just did the meaningful use through Medicaid.
So the EHR incentive payment system, which is also the meaningful use program, you could only do Medicare or Medicaid for the EHR incentive payments. Through the MIPS program, if you qualify for MIPS, you'll be able to score yourself on the using advanced information, the meaningful use section. You'll get a score there that will be part of your overall composite. You could also lose money. So you could gain or lose money based on what you're doing and how well you're doing compared to others.
So we're a health department. So do you look at that measure, then you're going to take the total health department? Because health department is kind of unique.
You get to pick, there's a whole methodology in here about groups or individuals. And you get to decide if you're going to do group reporting or individual reporting. And again, that's part of the complexity of how it works. But we're anticipating a lot of people will do group reporting because a lot of people already do group reporting and function in groups. Up here.
Has CMS really discussed anything about audits for the new program? Because I know right now a lot of meaningful use providers who have attested are going through audits, but will the burden of proof be on the provider when they're submitting their data, or is it going to come up after they've submit their data?
You know, I just have to say I don't know enough information there to actually comment. I haven't read in depth the audit portion of the rule. I would assume there's a big portion in the rule about the audit rules. And I just don't want to comment on something I don't know. But look at the rule if that's a concern of yours and see if you think the rule makes sense, is what I would tell you. We have a mandate from Congress to make sure that we are not tolerating fraud. And so our congressional mandate to have program integrity and avoid fraud is persistent across all of our programs and models, and will continue to be a goal of ours as CMS to really be good stewards of taxpayer dollars.
All right, I'll ask a question as I'm walking up. So, touching on what Jason mentioned earlier, there were 15 people in the room at the beginning of the session a couple years ago. And so when we get together in a couple years, let's say 3 years from now, and we have 400 people in the room, what do you think we'll be talking about as far as the top 2 or 3 greatest successes and the top 2 or 3 greatest challenges that still face us?
So the successes, I think you'll have data flowing and you'll have people actually doing projects and doing improvement and getting incentive payments based on their quality outcomes. A story about that, the hospital I was at, when to a bunch of electronic reporting. We dived into meaningful use stage 1 reporting. A lot of people thought, oh, this is monkey business, it's worthless, it's useless, and they did it as a regulatory activity. We rolled up our sleeves and said, no, we're actually going to use this as a chance to build our internal capacity to do electronic measurement and reporting. What we found is that we could then redeploy. We had as the hospital measures, we had a team of nurses, really expert nurses, who spent most of their day after a patient was discharged tracking down care gaps, saying, we thought a patient got this, we can't find it in the record, so they spent the next 2 days hunting and searching through the record to see if they could find and prove that we actually had given care that we thought was appropriate. When we moved to real-time automated quality visibility in our chart, we found that in day 1 of the hospitalization, and those same nurses, instead of spending 2 days after discharge, actually went out to the floor and met with whoever it was and said, hey, we think this patient actually has a care gap. Can we close it? Can we give them this immunization before they're discharged? Can we make sure they get this heart failure education before they're discharged? It was our same people. We didn't have to hire new people. We actually had incredible quality experts who were much happier in their jobs because what they were doing is actually helping patients, solving problems, rather than combing through charts and trying to prove that we did care that we may or may not have done. So I think you'll have a lot more of those stories and a lot more of your practices because you have been investing in getting good, quality, real-time information visible and usable to your people. I think you'll still be discussing alignment. I think alignment is going to be a forever discussion. I don't think it's going to be a just now discussion. I think it's going to be a forever discussion because we have constantly changing priorities. We have emerging conditions and infections. We have changing demographics. We have increasing interest on behalf of many other players in the healthcare system to have visibility into what their choices are. With more people paying out of pocket in these consumer-directed health plans with high deductibles, they actually are going to want cost data, and so they're going to be pushing us to have cost transparency when we're say, wait a minute, we're tired, we've barely been able to get quality transparency, now you want me to have cost transparency? And they're going to be pushing for things that are more meaningful to them, like function, like care experience, like timeliness, friendliness. Those are some of the things I think that the more the consumer voice enters into this are going to be the ways that we're going to be pushed into, and we'll be spending less of our time on lab results and attainment of esoteric risk scores that don't mean things to people.
Thank you. All right, well, thank you, Dr. Larsen.
Thank you guys very much.